Well, good evening, everybody. Welcome to tonight's Question Lab. I am your host, Jeff Downing. Really glad that you could join us on what is a cold and snowy December evening here in St. Louis. If you're here with us, regardless of whether it's snowing or raining or warm out, either way, it probably means that you're getting into your step one prep, or really just trying to sharpen your understanding of some tricky immunology concepts. Either way, you are in the right place. Tonight, we're going to be working through several board-style questions that highlight classic mechanisms, patterns, and presentations that you really need to be able to recognize. So if this is your first time joining us here at Question Lab, the format is simple. We're going to walk through each question together. We're going to focus on how to think through it. We're going to highlight what matters and hopefully make sure that you walk away with something that you can use on your next block or exam. Tonight, as I said, we're tackling immunology, and I am excited to once again be joined by Dr. Abraham Titus. Abraham, would you mind introducing yourself to the crowd?
Of course. Thanks, Jeff. Well, my name is Abraham Titus. I am a Hematology Oncology Fellow at the University of South Alabama. It was a pleasure to be here today, and kind of excited to go over some immunology. It's one of those unspoken chapters that often gets missed, but there are a lot of high-yield topics that you would not otherwise really cover unless you spend time particularly looking at it. So I've helped many students from step 1, step 2, step 3. So I'm excited to go over some questions today and kind of break down, what the best way to answer these questions are.
Now, as Abraham said, we've been working with students for a long time, and I think this is maybe our 181st edition of Question Lab. I always have to check the number afterwards, so if I'm off by one, that's on me. But we started this during the pandemic back in 2020. But USMLE-Rx has been around for 20 years. It was launched in 2005. So we've spent a lot of time thinking about ways to help students succeed. So part of what we're going to be doing tonight is sharing our methodology, our ways of answering questions effectively. Partly because when you enter the Prometric Center on test day or wherever you're at, it's really important that you've got your technique down. Yes, it's important for you to know as much as you can and to hopefully master as much of this knowledge as you can, but you also have to have a good technique just so you can be very efficient. So with that being said, we'll share some of these tips as we go through this. So let's go ahead and get started. This is question 1. We've got 4 questions tonight. We will have, at the end of tonight's event, we're going to have a raffle where someone's going to walk away with a brand new subscription to RX 360 Plus. We also have a special offer for those who are interested in USMLE-Rx. So be sure to hang in there. You do need to be present in order to win. So question number 1, we have this up here on the screen, and something's missing, right? What don't you see? Well, you don't see the answer choices, and that's by design. Our first step is covering up those answer choices. For us, it's all about really focusing, and sometimes you're going to see answer choices that are in the world of USMLE, they are called distractors, right? The wrong answer choices, and they are designed to distract you, but we don't want to distract you yet, right? We want you to really focus on what is it you're trying to get to the bottom of. So we say, first up, cover up those answer choices, and then step 2, read the lead-in And, for those that are new to this, the lead-in is the actual question here. So in the case of question number 1, the question is, which of the following best describes the mechanism responsible for this patient's condition? Okay, so we've covered up the answer choices, but we read that lead in first rather than reading the scenario, reading that vignette, because we want to make sure we understand what it is we're looking for, right? So, we've got a patient here, and we know that we're going to be trying to discover, hey, what is it that what's the mechanism responsible. So knowing that, this again, I consider this a bit of a compass, right, that you can use as you are tackling the question. So now that we've read the lead in, now we read the vignette, because this is where all of the data sits. A 2-year-old boy is brought to the pediatrician's office by his parents because of a fever and cough for the past 3 days. He has a history of frequent ear infections, chronic diarrhea, and multiple hospitalizations for pneumonia. He is up to date with his vaccinations. X-ray of the chest demonstrates diffuse bilateral interstitial infiltrates. A bronchoalveolar lavage sample shows pneumocystis jirovecii, and immunoglobulin panel shows an IgA level of 62, IgM level of 380, and IgG level of 48.3. Okay, there's your data. There's what's going on with this patient. So once again, which of the following best describes the mechanism responsible for this patient's condition? And with that, I'm going to turn it over to Abraham.
All right, so we're starting off with kind of a pediatric case. That's where a lot of the immunology conditions we kind of will focus on some of this stuff, but also you will see in adults as well. So we're going to talk about what's high yield from this question, what's important to highlight and kind of keep in mind. You don't have to memorize the normal values for the immunoglobulins. I'll give them to you. That's something that you always have on a test day. So remember, there's a lab portion of it. Certain labs, it does help to kind of know off the top of your head to make it faster and save some time, but certain labs is all you can always look up. So immunoglobulin levels is not someone that I would recommend memorizing. So highlighting the key important words here, again, going back to the lead-in is the most important thing, the mechanism responsible for the patient's condition. Okay, so not just like what the diagnosis is, what's the mechanism behind it? So this is a multi-step question, and you kind of have to understand what the diagnosis is, what's happening in the situation, and then kind of think about what the mechanism is. So 2-year-old boy, you always want to think who you're dealing with. Fever, cough for the past 3 days. Okay, this could be anything. Frequent urine infections, chronic diarrhea, multiple hospitalizations for pneumonia. That's not typical for a 2-year-old, right? 2-year-olds shouldn't be, they get a little sick, they get a little cold or sniffles here and there, but shouldn't have pneumonia and all these like hospitalizations at this age. So something's going on. He's vaccinated, sure, and he has interstitial infiltrates in the lungs. There's something going on. There's a pneumonia going on. And then they do a BAL, bronchoalveolar lavage. So it's PCP, right? Pneumocystis jirovecii, or you call it PCP pneumonia, whatever you want to call it. That's an atypical bug. It's not something I would expect in someone this age. And then they do an immunoglobulin panel. So I will give you the values here. So IgA, the normal value is 76 to 390. So it's a low IgA. IgM is 50 to 300. So that's a high IgM. IgG is 650 to 1500. So that's 48. That's a low. So you have a low IgG, low IgA, high IgM. Okay, that's important to know on top of the clinical presentation. So what differentials are going through your mind? And then as we pull up the options here, you should already have a differential built in your mind. And then think about what the mechanism of that differential is. So let's look at the options here before we take an attempt. So we got our classic options here, A to E. I like to start with E and make my way up just to make sure I go through all the options and don't get caught up on the first one that I see that could be the answer. So option choice E, leukocyte, defective leukocyte function associated with antigen 1 integrin on phagocytes. We'll talk about what all these mean as well. Option choice D, defective interleukin 2 receptor gamma G chain. C, defective CD40L on T helper cells. Option choice B, defect in pre-B cell maturation. And option choice A, defect in NADPH oxidase and neutrophils. Now, these options all sound difficult, but they all represent one condition or the other. So even if you know this condition, you want to, in your mind, get into the habit of just think, okay, what does this mean? What does this mean? What does this mean? What does this mean? Each of them means something different and correlate to a different condition. So you want to get into that habit because the question could easily be phrased a different way to make you think of something else. But I want you guys to take your time, look at the options, look at the story, and think about what mechanism is responsible in this situation.
Okay, everybody. So we're going to launch the poll here in a second. Just wanted to give you one last look at all of that, all of the info within the vignette. And also note that because answer choice E is a little bit on the long side, it gets cut off within our within GoToWebinar. So make sure that you've got your answer choice kind of locked in your head, and let's go ahead and launch the poll. Go ahead and let us know which of the following best describes the mechanism responsible for this 2-year-old boy's condition. We typically remind everybody on during our question lab events that you should make sure that you answer every question on test day, and we definitely want you to answer every question here during question lab. So give it a rip. This is a learning opportunity, and regardless, idea is that you get these questions right on test day. Where are we? We've got about 62% of you voted. I'll give you just a few more seconds. Go ahead and lock in your answer, and then we'll give everybody a chance to see what the polls look like. Okay, so let's go ahead and kind of close the poll and share the results. Okay, about half of you went with answer choice C, defective CD40L on T helper cells. With answer choice D pulling in about 1 out of 5, maybe you guys. And then answer choices A and B followed on the tail there, and then a few of you went with answer choice E. So let's go ahead and going to close the poll, and let's go ahead and reveal the answer. And the answer is indeed answer choice C, defective CD40L on T helper cells. So nice way to start off tonight's question lab. But if you didn't get it right, or if you got it right but you're not quite sure why, that's okay. Abraham is here to walk us through it.
All right, great job, guys. Again, these questions can get a little tricky, especially because they're very basic science heavy. They talk a lot about kind of what's happening on a cellular level, as opposed to the clinical stuff that we may be more used to when we kind of take care of patients. But these are all very high yield and very, very much a step 1 style question. So let's go through. Let's kind of figure out diagnosis and then figure out what's going on. So the classic story here is a child with recurrent infections getting an atypical infection, right? Pneumonia with PCP. It's a weird one. They check immunoglobulins and they find that she has a high IgM but low IgA and IgG, right? We know all of these immunoglobulins are needed for a good immune system. And if we only have a lot of IgM, the problem is probably class switching, right? We know whenever we make these immunoglobulins, the first one we make is an IgM. IgM is kind of our base level. And then we use kind of different markers to convert it into making IgG, IgA, IgE. And kind of we need all of them to have its effect in order to do certain things. For example, IgA is needed for mucosal layers. IgE is needed to mediate allergies and immune response to allergy stuff. And then IgG is kind of our long-lasting immunity and kind of some more of the chronic stuff, the infections that we treat. IgG gets involved in there. So We're going to talk about the other options, but the reason why C is the correct answer is CD40 is present on these T helper cells, okay? And they're needed for these B cells to class switch. That's the word they're going to use, class switching immunoglobulins, right? Where are our immunoglobulins made? The immunoglobulins are made by our B cells. Okay, in order for the B cells to switch from an IgM factory to make IgA and IgG factory, it needs these T helper cells, they're the helpers, to bring in this thing called CD40L and signal to the B, hey, switch to something else. If you don't have that connection, then the B cells will only stick with the base level, the factory that only makes IgM. So it makes IgM, IgM, IgM. So IgM levels will be really high. Everything else will be really low. So you need kind of that class switch ability, which is missing whenever you lose that CD40. It's a little factoid-based memorization heavy, but once you kind of understand the concept of it, it will just kind of make sense to you. And good job if you got that right. Let's talk about some of the other ones as well. Again, CD40 ligand, again, is an excellent recessive condition. That's also a question they can ask. And it can lead to opportunistic infections, and particularly mucosal. So you're going to get the sinopulmonary opportunistic infections because IgA is missing. Let's go through the other options here. So option choice E was a big one, right? So that was not many of you guys picked that one, which is correctly didn't pick that one. That one has got to do with leukocyte function and integrin. When I think about the word integrin, you want to think about migration and chemotaxis. So these are the people that have recurrent skin infections and mucosal infections and impaired wound healing because their neutrophils can't make it into their tissue. You don't have that migration ability. That's what's lost. Well, option choice D, right? 2R gamma chain. So that's SCID. That's my severe combined immunodeficiency. So in this one, they'll get viral, fungal, protozoal, all kinds of infections. Patients are super sick, and they're gonna, show low levels of IgM, IgA. Everything would be low. It's not particular to hyper IgM. So that's going to be my SCID, severe combined immunodeficiency. Option choice B is a precursor pre-B cell maturation. That's my Bruton. Whenever I heard pre-B maturation, think Bruton's agammaglobulinemia. That's the one where you kind of, that Bruton tyrosine kinase, which helps in the development of B cells and making it mature, is defective. So if that's defective, you just don't make all your immunoglobulins go down. So it's not, you get hyper IgM and everything else goes down. So that's why B is not the right answer. And then option choice A, a lot of you guys picked that one. That's our classic picture of you don't have that reactive oxygen species and you get the defect in that NADPH oxidase and neutrophil. So that's CGD, chronic granulomatous disease. Another high yield immunologic condition. That one's also very highly tested. So you should make sure you look up CGD. But good job, guys. I kind of talked on for a little bit here, but the really high yield, lots of, all these options are different questions they can ask. Definitely take time to go through these.
Okay, excellent. Thank you, Abraham. So we're off and running. Let's keep the momentum up with question number 2. As you'll see, we've covered up these answer choices, but you also see a radiograph there, an X-ray. So let's start off by reading that lead-in. Which of the following medications most likely contributed to the patient's symptoms? Okay, so you can see that we've got an X-ray in front of us. We're going to be trying to figure out what medications may have caused or exacerbated some patient problems. So again, that's as you're reading that that lead-in, always kind of thinking about, well, what are the things that I need to keep an eye out for as I'm going through the vignette. So with that, let's go ahead and do that now. A 25-year-old woman comes to the clinic with a 4-week history of hip pain. She recalls no injury to the hip. Her past medical history is notable for ulcerative colitis, requiring several admissions for flares. The patient is afebrile. On physical examination, there's tenderness of her right hip. X-ray of the hip is shown. So once again, which of the following medications most likely contributed to the patient's symptoms? Think of that. You may already have some ideas in mind. It's always good to try to get your hypothesis down even before you see answer choices. So think about that as I pass it over to Abraham.
All right, so we have another multi-step question, right? So we have a picture here in this time, though. It's going to change it up. And we got an adult, right? 25-year-old, young adult, but still an adult. So let's go through, let's highlight some keywords here, and let's try to figure out what they're really trying to get at and what the question is asking here. Again, lead-in is always important. It's not asking about diagnosis. It's asking about medication most likely contributed to patient symptoms. So you have to read the story, get a diagnosis, use the picture, everything to combine to build a story in your mind. Then you want to think about, okay, what caused this, right? It's not mechanism action or anything. It's about what, just give me medication that caused it. And the options will all be medications. You got to think about, okay, what is the underlying cause? What could have caused this situation? So we got a 25-year-old woman, 4 weeks of hip pain. Okay, she's kind of young to have hip pain. No injury or anything like that. History of ulcerative colitis. Okay, that's important to know. And has had multiple hospital admissions. Currently not febrile or anything, and has tenderness. And really, it's a short vignette. Some of these can be easier. Sometimes it can be really hard when they give you short because there's not much information you can draw from. But the shorter they are, the more each word has a lot of weight behind it. So you want to look at the story and really understand what's going on. The X-ray here is also a big clue. Again, you don't have to be a radiologist. You don't have to read every X-ray in detail, but there are some kind of classic findings on this X-ray. And if you don't see it, that's okay. We'll go over it. But even without the X-ray, I should be able to get to this answer. So let's take a moment, think about what the diagnosis could be as we put the list of medications out there. All right, so we have classic A to E. We want to think about what could this be. Option choice E, methylprednisolone. Option choice D, methotrexate. Option choice C, mesalamine. Option choice B, fluticasone. Option choice A, cyclosporin. Right? So these are all medications the patient could possibly be on, right? She has ulcerative colitis. These are all ulcerative colitis treatment medications. But what is most likely to cause the patient's problem and the X-ray finding in this situation? So definitely a shorter question, but just as high yield. And this is a topic that they definitely want you to know. And pharmacology is something that's going to be sticking around for step 1, step 2, especially, and beyond. So this is a high yield topic for sure. So take a moment, think of a diagnosis. If you know the diagnosis, you can drop it in the question box and pick an answer.
Okay, let's go ahead and launch the poll. Give you guys a chance to let us know which of the following meds most likely contributed to this 25-year-old woman's symptoms. Hopefully you're able to take a good look at the X-ray and have a sense of what it's showing, what's going on. Let's see. Good to see folks jumping into the question box. Just so you know, you can use the question box to follow up, or if you've got additional comments, we love to hear from you. Sometimes it's challenging for just the two of us to answer every question in there, but definitely love hearing your thoughts on that and hearing the diagnoses that you're homing in on. Okay, well, it looks like almost 80% of you have voted, so let's go ahead and close the poll, and we're going to share the results. Okay, so I don't know. I might be overestimating this, but I'm not sure if we've had a question or an answer choice that has drawn that high a percentage. Methylprednisolone here got 83% of the votes. I struggle to recall any answer choice where we've gotten over 80%. So a very clear and decisive favorite here. Few of you went with methotrexate and cyclosporin, and a few others with fluticasone and mesalamine, but this is it was all about answer choice E. So let's go ahead. I'm going to close the poll and let us reveal the answer. And the answer is indeed answer choice E, methylprednisolone. So good job, everybody. That is really almost an unprecedented response. But regardless, some of you may be wondering about that, or some of you may be wondering about some of those other answer choices. So I'm going to let Abraham walk us through it.
All right, great job, guys. And I see a lot of you guys putting the right diagnosis in the chat box as well. So this is indeed avascular necrosis of the femoral head. And the underlying or the implicating drug in the situation is methylprednisolone, or any kind of steroid in the situation. So we're going to talk about it. Let's kind of break through here. Let's go through the x-ray. I see a lot of people asking about how can we tell based on the x-ray what we're dealing with here. So we'll walk through that as well, and kind of, also, even if you didn't get the x-ray, you can still get to the answer using the differentials in the situation. So again, the patient has ulcerative colitis, right? So the general treatment for ulcerative colitis is immunosuppression, right? So typically in short terms, we like steroids. It's like a good Band-Aid fix in these situations. But long term, you want to put them on something that's more long acting and kind of can have less side effects than short-term steroids. So the patient has recent hospital admissions, flares. So this patient probably got quite a bit of a steroid exposure. Now, first of all, let's kind of go through the other options. Then we're going to break down what we see on the x-ray. Okay, so the other options, cyclosporin. Cyclosporin is also an immunosuppressant. It's a calcineurin inhibitor or interleukin-2 inhibitor through the calcineurin suppression. And cyclosporin generally, you're not thinking about avascular necrosis of the femoral head. These people have increased risk for infection. Nausea can be another common side effect of these people. Generally not this. Fluticasone. Well, fluticasone is a steroid technically. Well, why is that not the answer? Well, it's an inhaled corticosteroid. Those did not tend to have systemic effects, and those did not tend to have effects that would cause this, right? The amount of absorption you're going to get, it's mostly working in the lung and mostly for asthma COPD kind of situation. Mesalamine, it's a 5-aminosalicylic acid. We use it, and it's typically minimal side effects. It's kind of like nausea, headaches, but not really avascular necrosis. And methotrexate has got tons of side effects, but this is not one of them. It's a folic acid metabolizer inhibitor, and you got to think about myelosuppression affecting the stem cells because the folic acid is affected. Okay, let's get back to this. Let's look at the X-ray here. So the main finding you're going to see that gives away avascular necrosis of the femoral head is going to be obviously hip pain. It's going to be the radiograph findings. The radiograph is going to show lucency at the femoral head. Okay, so if I look at the very tip of the femur here, you're going to see some lucency there. It means that it's not as white as you would expect, right? So you see that little kind of looks like almost a crack in the tip of the femur head. That's that white part there. That's the lucency. It's a little hard to tell until you've seen a few of them and you compare it to the normal. It should normally be a nice round shape and go all the way into the hip bone. If I have that lucency or that kind of missing piece there, that can be a good finding. By itself, I would probably have struggle as well. So we're not radiologists, we can't catch it right away. But using the history, using the story, you should be able to get to the answer for sure. And step one is not expecting you to just look at the image and be, okay, that's avascular necrosis right away. But they're expecting you to use a story. And then if you think it's avascular necrosis based on the story, you look at the x-ray and you look for that. You kind of make yourself see that little lucency at that tip of that femur. Right at that femoral head there, you kind of see that little less white spot and that dark spot there where it goes into the hip bone. And that's what gives away the answer. And this is something that we always have to warn patients about. If the patient has hip pain or anything like that, you got to stop this. Avascular necrosis can be very dangerous, and you got to make sure that essentially you're cutting off the blood supply to the bone, so you can actually cause permanent damage and necrosis of the bone. And this is true for both oral and IV steroids. As long as it's systemic, that effect can still be present. So very high yield, being able to recognize it early is important, but also when you talk to patients, you have to always warn them about this whenever you prescribe long-term steroids especially. But good job, guys. I'm glad to see everyone slam dunk this one. Definitely a high yield topic, and I'm sure you guys have been asked about this in the past.
Okay, 83%. That's phenomenal. You guys are doing great. Let's open up the question and kind of the structure here a little bit, kind of similar, right? We've got a patient photo and kind of a relatively slim vignette. So let's go ahead and let's read the lead in. Of course, we have those answer choices covered up first. And the lead in goes, which of the following additional findings is most likely to be associated with this patient's condition? Okay, so again, we're going to have to figure out what this patient's condition is, and what additional findings you might be able to link with it. So now that we've got our compass, we know the direction that we're moving in. Let's jump into the vignette. A 57-year-old woman comes to the clinic because of joint pain and stiffness for the past several years. Her symptoms have worsened during the past 2 months and are at their worst upon waking. Both wrists and knees are stiff for over an hour each morning. Findings on physical examination are shown. So again, which of the following additional findings is most likely to be associated with this patient's condition? Perhaps there's something jumping out at you here where you are already thinking about the findings that might accompany this. But while you think about that, I'm going to pass it over to Abraham.
All right. So, like Jeff said, it's a very similar situation. We got a picture, and now instead of kind of an X-ray, we're dealing with the actual clinical picture. And some classic findings on this image. If you don't recognize it, it's okay. And then we got a story, right? So you want to use the combination of the two. You want to look at what's the high yield terminologies, and before you pick an answer. So let's go through. Let's highlight some of the keywords here, and let's read the lead in one more time to make sure we're not missing what we're doing for. So again, additional finding most likely be associated. So it's not asking about diagnosis, not asking about in addition to whatever this picture is showing, what else are you going to see? So you want to diagnose the patient, think about all the things that you can possibly see in this patient, and then come up with an answer. We got a 57-year-old woman, and she has joint pain and stiffness. Okay, several years. Okay, it's been going on for a while. Symptoms have worsened in the past 2 months, and they're worst upon waking up. It involves both her wrists, both her knees, and they're stiff for over an hour each morning, right? So this should be ringing some bells right away. Should make you guys think about what the diagnosis could be. And even if the story didn't give it away, the picture should also give it away. So you should kind of think about what the differentials could be. If you guys think of a diagnosis, you guys could throw it in the question box just like last time, and you guys can think about what could this be. Now, you want to get the diagnosis, but also think about, okay, what are the other features that are commonly seen in this diagnosis? And that's what these options are going to show you. They're going to show you a bunch of different symptoms or different findings you might see in this patient. And you want to connect that to what the patient has. So let's go through. Let's pull up the options here and start to think about what this could be. All right. So we have 5 options again, just like the usual. I like to start with E and make my way to the top. So option choice E is swelling of the distal interphalangeal joints. Option choice D, skin nodules composed of uric acid. Option choice C, deviation of fingers towards the 5th digit. Option choice B, dactylitis. Option choice A, clubbing of the fingers and toes. So, what is a diagnosis, first of all? Then think about, okay, what are some findings I'm going to see in this patient that's, also seen in this diagnosis, an additional finding? And which of these 5 makes the most sense in that situation? Okay, so just imagine this patient's walking into your clinic. What else are you going to look for in this patient? So take your time. Go through the vignette one more time if you need to. And let's pick the best answer possible.
Okay, we're going to go ahead and launch that poll. You've gotten a good sense of this 57-year-old patient struggling because of joint pain and stiffness. What else do you think you would see when this patient presents? Interesting one. Just a reminder, we'll have a raffle coming up here just a few after we do question number 4. I've also got that special offer out there for you. Good time to lock in those savings. The promo closes tomorrow, but if you could actually say you're going to start your step 1 studying in January, you could actually go ahead, purchase it now, and then set your subscription to start once you're ready to hit the books after the holidays. So keep that in mind as you're weighing your options. Let's see, we are at 3/4 of you have voted. And interestingly enough, we've got another case where got a pretty strong leader. So I'm going to go ahead and close the poll and share the results. Not quite 83%, but just about 2/3 of you went with deviation of the fingers toward the 5th digit. Obviously a lot of things here kind of connected to fingers and joints. So, almost 20% of you went with swelling of the distal interphalangeal joints. Some of you went with skin nodules composed of uric acid, and a few of you went with dactylitis and the clubbing of the fingers and toes. Okay, so with that, let's go ahead and close those results and reveal the answer. And you guys did it again. Answer choice C, deviation of the fingers toward the 5th digit. So once again, well done. Applause for all of you. Even if you didn't get it right, that's okay. The crowd is doing well. Maybe you haven't gotten any of these right, which is okay. This is exactly why we're here, because we want to make sure that you get all of this down pat so that you can get it right on test day. So with that, I'm going to hand it back over to Abraham to walk us through this one.
Great job again, guys. So this is a kind of a classic presentation. So we wanted to cover most of the high yield classic findings. You got the immunosuppressive conditions for question 1. You have our classic avascular necrosis. And then we have, like a lot of you guys mentioned in the question box, this is rheumatoid arthritis, right? So classic RA. So what are we dealing with here? What are some of the classic findings we see in RA? This is a typical patient, right? So 57-year-old middle-aged woman coming in with joint pain. Stiffness is going to be the buzzword here. Waking up in the morning feeling stiff for over an hour. So that's a classic RA finding, right? So as opposed to your osteoarthritis, where the stiffness tends to be at the end of the day and the pain is worse at the end of the day. The way I think about this is that in RA, it's an inflammatory condition, right? So the problem is this inflammation and gunk built up in your joints. And when you wake up in the morning, it's been sitting there all night. So you're stiff in the morning. So only once you get moving, you get that fluid out of your joints and it gets easier to move throughout the day. So the stiffness is in the morning. Whereas osteoarthritis is an overuse problem. It's a problem where your joints have just been overused over the years and you tend to have stiffness and pain. And that happens at the end of the day because you've been standing all day, you've been using your joints all day. That's when the pain really hits. So knowing that difference, knowing some of the classic presentations of it and separating them is also important. Also, rheumatoid is very classically symmetrical. So affecting both the wrist, both the knees, that's a very classic finding. So symmetrical findings. Okay. And what are we seeing in this picture here? So that's a kind of a classic finding, right? So these kind of classic findings of these nodules that are seen in the body. That's also very classic, and that's kind of what they're trying to show in the picture here. Okay, so symmetric inflammatory polyarthritis, typically middle-aged, typically bilateral swelling, and then worse with morning stiffness. You can have these firm, painless nodules that are present, and they're called rheumatoid nodules in the elbow or the hand typically. Okay, so that's a thing. Now, let's look at the options. Let's figure out what's going on here. I know a lot of you guys picked C, but what do they mean by deviation of the fingers towards the fifth digit? That's very important, right? That's a very classic finding, right? So I always think about what's the fifth digit? The pinky. So everything's aiming towards the pinky. Okay, ulnar deviation is the other word that they'll sometimes use. So you're pointing towards the pinky. So your wrist turns to the right. I saw somebody call it a swan neck deformity. That's also a classic, kind of an older terminology that they used to use all the time. So that's an important finding to find as well. So that's very classic. What about these other options, right? So option E, swelling of the distal, DIP, right? Remember, DIP, I think osteoarthritis. So that's the Heberden nodules that nodes will see in osteoarthritis. And typically, that's going to be the morning stiffness is not going to be up to an hour. It's going to be less than an hour. And it's going to more likely affect some of the large joints of the body, like the knees and the hips, because that's where most of our stress of the body is put, right? So that's an important thing to understand. Okay, so that's option E. So option E is trying to point at osteoarthritis. Okay, what about D, skin nodules composed of uric acid? Well, that's straightforward, right? Uric acid, you want to think gout, right? That's gout, uric acid crystals building up in soft tissues and joints, and that can cause chronic gout, and that can cause pain. Option choice B, dactylitis. What is dactylitis? That's inflammation of the fingers and toes, right? Sausage digits. Think about that as psoriatic arthritis. So psoriasis with arthritis, psoriatic arthritis. Dactylitis is the classic finding. Sausage findings. There's an X-ray finding called pencil in a cup finding. So this is going to rheumatology world, and a lot of high yield topics in that one as well. And then option choice A, clubbing of the fingers and toes. Think about that as your paraneoplastic syndromes, hypertrophic osteoarthropathies that can happen. So cancers you want to think about, and then lung conditions. So really bad chronic obstructive disease like COPDs can have clubbing of the fingers. Cancers of the lungs can have particularly findings. And these are kind of classic findings that they like to test, and you want to be able to aware of it. But in this situation, the deviation of the fingers towards the fifth digit is something that we see typically in rheumatoid arthritis, and the clinical story is also pointing to rheumatoid arthritis. And also, it's good to run through the differentials here, understand what each of these other things are, and being able to kind of come up with an answer from that situation. So good job, guys.
Okay, nice work, everyone. Well, with that, we have reached the final question for tonight's question lab, question number 4. And we're going to take a look to see what is in the cleanup spot. No images this time, but we do have all of those answer choices covered up. So we'll start off with the lead-in. Which of the following antibodies is most likely to be found in the serum of this patient? Okay, so once again, we're going to have to, kind of figure out what's going on and, what we might expect here. So get a little chemical here, right? So with that, let's read the vignette. A 17-year-old girl is brought to the clinic with a swollen and painful left elbow for one day. She had similar symptoms in her right knee the previous week. Her history indicates she is not sexually active. Her temperature is 38.2. Physical examination is notable for several oral ulcers, as well as swelling and tenderness in the left elbow and right knee. Laboratory tests reveal a hematocrit of 31%. The result of a venereal disease research laboratory test is positive with a negative blood FTA-ABS test. So again, which of the following antibodies is most likely to be found in the serum of this patient? Some of you may already have a read on what's going on with this patient. Maybe have a guess or a hypothesis. So let us know there in the question box as I turned it over to Abraham.
All right, so kind of going down the middle again now, we have a younger female, like a like teenager, 17-year-old. That's important to understand. And we have kind of a different lead in here talking about antibodies in this patient and trying to figure out what's going on. Definitely a beefier vignette, but definitely not the beefiest you're going to see. There's much bigger ones you'll see on exam day sometimes, but they do have all the relevant information here. So you need to kind of read through it, look at the lab values, look at the clinical presentation, and come up with a diagnosis. Okay, so I already see people saying diagnosis in the question box, which I like to see that. Continue dropping that in if you kind of feel like you know what's going on with this patient. Okay, let's go through, let's highlight some keywords here, and let's try to figure out exactly what's happening. Again, the question, antibody. So not only just diagnosis, you got to think about what antibody are they most likely to have in the serum of this patient. You got a 17-year-old girl, swollen and painful left elbow for 1 day. Okay, not very long, 1 day. Similar symptoms of her right knee the previous week. Interesting. She's not sexually active. She has low-grade fever, 100.8, and has several oral ulcers. Okay, and has tenderness, left elbow, right knee, so multiple joints. Hematocrit is 31. Her VDRL is positive. So venereal disease research laboratory test, right? That's a VDRL. Negative blood for FTA ABS. So we're going to talk about what these mean and what the overall clinical situation is pointing towards here. Okay, so there are some key important factors here, and look at the full story, see what's going on, look at highlighted, look at not highlighted stuff as well, and think about what antibody could be found in the serum of this patient. So let's go through, let's pull the options up here. Let's figure out what's happening. All right, so we got a bunch of antibodies, right? So they all have anti-something. So E, anti-cyclic citrullinated protein, or CCP. Option choice D, anti-centromere. Option choice C, anti-double-stranded DNA. Option choice B, anti-Jo1. Option choice A, anti-IgG. Now, all of these have kind of relevance in different conditions associated with them. You want to think about what could this be, what could be the answer, and what fits the situation the best. I see some people saying the correct diagnosis in the option box. And take your time, think about what's happening, what could be the antibody in this situation, and go ahead and pick the answer.
Okay, everybody, we're going to go ahead and we're going to launch the final poll. And you can tell us which of these antibodies is most likely to be found in the serum of this 17-year-old girl. Once again, hats off to everybody here. You guys have done a nice job. Love seeing all of the questions and the responses in the question box. It's a good active group. Especially appreciate that because you really can't be passive when you are preparing for the boards, right? You can't really just sit back and try to absorb stuff. You really have to, actively kind of seek out knowledge and figure out what you know and what you don't know. That's kind of our motto here is just, keep testing yourself, keep figuring out where your gaps are, keep figuring out what it is that you need you still need to master, because you guys are going to be lifelong learners, right? So this is just one step. Okay, we've got about 3/4 of you have voted. Give just a few more seconds. Any of you that might just be like, is it this or this? I'm not sure. That's all right. Take your best shot, and we'll go ahead and close the poll and share the results. Okay. So once again, a little over half of you went with answer choice C, anti-double-stranded DNA, um, and kind of a mix here between anticyclic citrullinated protein, anti-Jo1, anti-IgE. Um, Not many votes for anti-centromere, so not many of you are expecting to see that. Okay, well, with that, let's go ahead and close the poll, and we'll reveal the answer. And the answer choice is indeed anti-double-stranded DNA. Answer choice C. So great job, everybody. Um, again, when it's not the biggest deal, right? That you guys did so well on on these questions. I mean, this is all about learning, but definitely hats off for all of you for doing so well here. So great work. If you didn't get it right, or if you're not quite sure why you got it right, or you want to make sure that you were on the right track, um, that's why we're here. And I'm going to pass it over to Abraham one more time to walk us through the explanations.
All right, great job, guys. 4 for 4. Love to see that. Again, another very high yield topic, and there's some hidden stuff in here which I'll also like to talk about, which kind of makes this even more high yield. Okay, so our classic situation here, I saw a lot of people drop differentials in the question box, and lupus was the diagnosis. So SLE, right? So this is a young lady. She has kind of a systemic problems, right? So not just joints, right? She has the joints pains, but she has oral ulcers going on, and then has like this fever out of nowhere, which doesn't make any sense, right? So she has kind of a vague symptoms. Lupus should be thinking about systemic inflammation. Okay, systemic lupus erythematosus. Now, I see some people put, septic arthritis. Nope, you want to think about that would be one single joint and it would just stay painful and febrile with it. It's a good differential, but the fact that she's had pain in different joints and the oral ulcer is kind of point away from that. What about Behçet's disease? Well, Behçet's disease, you can see ulcers in the mouth as well. That's a different one that's someone had in the answer box. That's also a good option, but not necessarily what's happening in the situation. Doesn't explain everything that's going on. So let's understand what's happening here and why do they kind of go into this VRL thing? VRL is a test we use for syphilis. What's that got to do with lupus? What's that have to do with any of this stuff? Well, people that have lupus will often have false positive VDRLs. That's kind of a classic finding, okay? So that false positive VDRL is kind of a clue here. But then the confirmatory test for syphilis is the FTA ABS, right? And that was negative. So it's a false positive VDRL, which can be seen in things like antiphospholipid syndrome, lupus. There's a few other conditions that you can see that in. Whenever you have that anticardiolipin antigen that it reacts to, that's whenever you get that positive VDRL testing. So it's kind of a lab error that occurs that we found out, okay, if you happen to see that, think about lupus. The other thing you want to think about it, they give you a hematocrit of 31. That just means anemia, right? So anemia is commonly seen in lupus, right? You have destruction of red blood cells. You can have kind of a chronic inflammatory pattern, which causes anemia of chronic disease as well. So multiple reasons why, okay? And remember, lupus is a chronic multi-system autoimmune disorder. So it can affect like anything technically. Inflammation of the pericardium, the pleura, the skin, the kidney, the blood counts can go down. You can have seizures, you can have encephalitis. So any kind of inflammation you can typically kind of present with lupus. Obviously the classic butterfly rash is there, but there's a reason why they're not giving that to you, because everyone sees that, they pick lupus. If you want to expand your thought for lupus and not just the skin butterfly rash, but also any organ or any system can be affected in lupus. So that's kind of one of those things that can mimic its other things as well. So let's go through the options here. We said anti-double-stranded DNA, that's classic for lupus. That's something that we can see in lupus, and that would explain. The one that's a little more specific for lupus is going to be anti-Smith antibodies that somebody also mentioned in the note in the question box, which is great. What about the other options here? Well, we have anti-IgG. That's something that is typically seen in rheumatoid arthritis. So it's anti-IgG antibodies. anti-Jo1. That's kind of your inflammatory myopathies, right? So your polymyositis, dermatomyositis, think more muscle inflammation, elevated CK, inflammatory pattern. And this patient doesn't, and oral ulcers and the joint stuff doesn't really fit with anti-Jo1. Anti-centromere, not a lot of you guys picked that one, but that is got to do with my CREST syndrome, limited cutaneous form of that systemic sclerosis. The CREST syndrome, the Raynaud's phenomenon, esophageal dysmotility, all the classic findings of CREST. That's going to be an anti-centromere antibody. There is a nice chart on first aid that goes through all the antibodies and which disease associated with it. Definitely worth covering up the side and trying to figure it out and just doing that again and again until you get it. It is a little memorization heavy, but it is very easy points on exam day if you do kind of learn that properly the first time. And finally, we have anti-CCP, right? Cyclic citrulline protein. That's a lot of you guys picked that one. That's also another finding in RA. So that's more specific than my rheumatoid factor antibody, but this is the kind of the confirmatory test we can do for rheumatoid arthritis. So high yield here, and this is not rheumatoid arthritis. This is a young female coming in with kind of systemic inflammation. So think autoimmune, think lupus, anti-double-stranded DNA. But great job, guys. Immunology, it's a lot of little details, a lot of little basic science stuff, but if you get it, you get it, and those are free points on the exam. You don't want to mess those. Good job.
Okay, everybody. Yes, once again, well done, everyone. You guys, you were really locked in, no doubt about it. And hopefully you were able to pick up some new tidbits and some more knowledge so that your immunological base is strong going into the next stage of your test prep. We do have the test available for you. So let me see if I can get into the chat here and just drop the link to the test. So again, nice thing about the when you're going into RX is that we've got more information on how you can get to the correct answer, as well as additional rationales and even more information, especially if there were topics tonight where you felt like you'd like to supplement some of your current knowledge. So anyway, you can again screenshot that, or you can go to the link there in the chat.